Welcome to the JEMS Report, brought to you by Clarion Events, Fire and Rescue Group, and the Journal of Emergency Medical Services. My name is Ted Lee, and I'm the editor-in-chief of JEMS Magazine, along with Jeff Frankel, our managing editor. We will be bringing you industry leaders and subject matter experts on all things EMS and pre-hospital medicine related. Today, we have a very special guest and an author for JEMS. Colonel Michael Wissemann is an RN and nationally registered EMT. And he wrote an article for us regarding artificial intelligence. Sir, thank you for joining me today. I appreciate you taking time out of your busy day.
Thanks for having me, Dr. Lee. I appreciate it.
So why don't you give our audience a little bit of your background, kind of, who you are, what you've been doing, and then segue into, why artificial intelligence was a topic that you were interested in, and why is it such a pressing issue?
Oh, yeah, absolutely. Well, again, thanks for having me. I've been an EMT for approximately the last 3 decades. It sounds like a really long time when I say it that way, right? Not quite back to Johnny and Roy, but I started as an EMT. I was going to school here in central Pennsylvania and wound up going into the RN program. Got my commission through the Army, and for the last 25 years, I've been an active duty Army officer. Throughout my career, I've done a lot of clinical care. I've also continued to volunteer in different areas as I've moved across the country and across the world, to include Pennsylvania, New Mexico, and Northern Virginia and Fairfax County. A great system there and really great experiences. But as I went to the War College with the Army, most recently, probably about 5 years ago, we did a lot of reading on artificial intelligence. And there's a great opportunity to mix artificial intelligence and healthcare, which is coming around right now. But I think EMS is lagging a little bit in its adoption.
Very pointed topic. Everybody seems to be pretty recently losing their mind over AI and what AI could be. I enjoyed your article, but it was kind of funny that you mentioned Baymax, the personal healthcare companion from Big Hero 6, and then you also mentioned Skynet. And, that's the generational aspect of it. You've got the younger generation that's kind of used to the technology and embracing the technology and all the great things that it could be. And then you have the older generation, the gray generation that has been around for a while. That's like, yeah, this is Skynet, this is Terminator. They're going to take over. This is going to be a problem for us. And the reality is probably somewhere in between. But it is a great opportunity for us to kind of leverage the technology. And EMS for a long time has been one of the professions that jumps on technology, even though it might not necessarily be ready for it or the greatest application for it. But in time, it usually plays out.
Yeah, I think to assuage some concerns of people my age and a little bit older in Skynet, there's 2 great terms to consider. It's, human on the loop and human in the loop. I think when Skynet came around, right, there's human in the loop where, we have a circle and there's always a human making some sort of contact and driving the changes. At some point, it becomes human on the loop where things are just working on their own and there's someone on the outside looking in, as opposed to signing off on everything. So those are 2 great terms as we talk about AI. You talk about Baymax, and that was really more of a human on the loop, right? Where he's got the ability to do everything and run independently. And we're starting to see within healthcare some really great opportunities. And I think, just right now off the top of my head, we're seeing a lot of AI assisting providers in cancer diagnoses, which is a huge thing, right? They can see and process tens of thousands of images and develop a database and say, hey, you may have missed this, which is great when we're working in conjunction.
Yeah. Well, to your point about being able to process so much faster and so much more information, of course, that's the leverage of the technology and kind of the beauty of it. You're still having human eyes on it, still having, the ability to look at it and make sure, yes, in this case, this is true, or no, this is an outstanding case, this is not true. But just the sheer volume of being able to look through. And, one of the things with EMS, we're getting very, research and data centric, and a lot of things that we're doing. And I think AI has the opportunity, or use of AI has the opportunity for us to really leverage the data that we're starting to collect from EMS.
100% on a national level, right? Some of that data is out there, and you can go to the EMS database portal, and I think we're up to 30 gigabytes, 57 million calls last year that are in the system, if I remember. And we've come a long way, Doc Lee, if you can remember from filling out bubble reports, right, for
Yep.
trip reports. So, and sometimes we bang our heads against the wall as providers. Oh man, why do we need all this information? Hopefully, it's going to drive change, right? We have to establish that data repository, that data dictionary, in order to see that, hey, this is what the vital signs were, and of these 57 million patients, 1 million experienced shock, and now let's take a look at all the vital signs on these. What could we have picked up a little bit earlier? Now, perhaps, right, someone's writing code when the blood pressure shows this trend. We're in a big, the alarm should be going off about shock. There's a lot of other things as well. I think, if you go back 30 years, no one would have imagined the civilian being able to deliver electricity in the form of an AED, right?
Right.
But we're seeing that, right? You go back 15 years and, hey, everyone's got to give compressions. Well, now we've got Lucas devices. And I think the next advent, as we talk about cardiac arrest in the back of an ambulance, was to say that we're not tying that EKG to a triple channel pump that can deliver lidocaine, epinephrine, or whatever it needs to be there, automated by reading that strip. They can see that strip. They've got, again, thousands and thousands of images that may be able to process that with the assistance of the paramedic. Hey, is this VFib? The machine says, yeah, this is VFib. Boom, they touch it. Hey, and the triple channel is delivering the meds we need.
Yeah.
Or the shock, for that matter.
I think, yeah, and the older generation, I think there's some concerns about the technology because we were adopting the technology so fast, and it's in its infancy, and things weren't perfect. We were looking at the monitors, and the monitor in the box was saying this is what the rhythm is, and you're looking at the rhythm, and you're like, that's not what that rhythm is. And a lot of times it went back to, poor information in, poor information out. If you had your leads misplaced, or, if you weren't doing things, exactly the way that they needed to be, of course, the information that was being given to you was bad. But we've gotten away from that now, to where we're much more likely to buy into it. We're much more research driven, like I mentioned before. The technology has come a whole lot farther. And to your point about cardiac arrest in the back and the use of pumps and would it deliver? I mean, just the technology is getting to the point where blood draw can be done and it can be analyzed, and actual dosing and different medications could be selected based on individual patient criteria, instead of us following protocols that are standard doses A. Everybody gets B. Everybody gets C, and you're like, okay, no, this is more tailored to that Baymax almost personal healthcare for the individual. So it is pretty interesting to think about that. You mentioned some AI stuff and things like dispatching and crew utilization. So what were some of the points that you were trying to make with that?
St. Louis recently adopted some AI ability to screen some of their calls, right? And we just imagine how busy dispatch is at any organization, let alone a major city. But everyone calls 911 for everything from police requests to down power lines and stuff like that. A lot of times their screening tools can now take off, I think it's 30 or 40% of their calls, and really get the emergency medical dispatcher really the calls that they need to attend to. So that's great, right? So it lessens the load on our dispatchers. It really allows them to engage on the calls and focus on the calls that they really need to. As we collect the data and we take a look at our districts, right, and if we're still using boxes out there or cross streets, maybe we know that between rush hour, because we're constantly seeing at this time in this area, we're seeing motor vehicle accidents or something like that. Maybe we stage a vehicle for an hour or for 90 minutes in the supermarket parking lot away from the station, because we know there's a greater chance of something happening in that location. At the very least, we know we're not trying to send it across town when it should be right where, right at that location.
Yeah.
So,
And some areas have been doing that for years and years. I mean, anecdotally, when we were working out in the field, we always knew that, when it was late at night, most of your calls are where the subdivisions are, where the homes are, because that's where people are, and then during the day, you're like, oh, rush hour, busy highway. We're going to have a call on the highway. We know we're going to have a call at least once. And then when they move to the schools or to the factories or the workplaces that they are, you knew that your call volume shifted in that. And, system status management always, a lot of people hated system status management, but it was to your point of, moving the resources to where they were really needed. To see that kind of adopted on a wider scale and to try to see what AI could do in kind of the predicting of calls, especially with the historical data that we have, could be making, pretty good inroads to reducing call volumes and really better utilization of the crews.
yeah, right resources at the right time at the right location, right? Almost like our rights for medications, right?
Right.
But the other thing this helps us sort of massage out of the equation is our confirmational bias, right? Where what I remember is I always remember going to this house. I'm always going to this house. Well, you know what? You might not always be going to this house. You might be remembering going to this house because of X, Y, or Z, right? Now we have something that's data driven and we can show it. And if that allows other stations and other organizations to make a case for better resources, hey, it's right there as well. That data is important. So again, it all comes back to the data, making sure we have quality data and so we have quality metrics coming out the backside. Yeah. So we talked, a little bit about the pre-staging personnel or, units, as well as, large events. I mentioned earlier to you offline, I'm going to be working at Beaver Stadium, home Penn State football, right? 107,000 people in that stadium on a Saturday, second largest stadium in the U.S. If we can predict where, right, I'm going to remember, man, the calls are always up on the upper deck. It's always the cardiac arrest up there, right?
Right.
Maybe it's not, right? Maybe we know that in the sun, when the temperature is this, if we're able to get that data in there, chances are of us seeing cardiac arrest are 30% or 70%. Well, now that we have that data and we're seeing that, how do we utilize that data, right? So we could predict who's going to have a cardiac arrest where, or or anything else, or those injuries, as we take a look at a large population like that.
Yeah. Well, you mentioned it, and of course, it's always a hot topic, HIPAA and patient rights and securing data and stuff like that. And of course, anytime that we have technology that potentially opens up for more data collection, that always becomes the concern. So yes, we have to be mindful of that. But you had mentioned that, the use of like wearable devices, Fitbits or Apple Watches or those type of things, could really open up opportunities for us, and especially in like event type things to where you're almost tracking people, and people aren't going to be happy about that for sure. But it might give you a clue to that. And one of the things that I was thinking of when I was reading your article on how interesting that was, I mean, people could opt in or opt out. But if you're going to an event, you're going to a concert or a sporting event or something, you've got to have a tag. You've got to have something, a ticket, something that gets you in. And, what if we had bans on people that were doing something like this, that were tracking to a certain degree, but it had parameters. If somebody's oxygen saturation fell below this, it would alert and you would be able to see kind of where that person was, or if their heart rate got too high or too low, or their blood pressure went. And it wouldn't necessarily be identifying you personally for it. It's just a number on a screen that says, hey, this is a high risk person and they're in this area of the event. I think that would be pretty cool.
Yeah, this is where I think some of my military writing ties into this, and I'll circle back around. But as we take a look at future conflicts that are not based on counterinsurgency warfare or irregular warfare, which we've been fighting for the last 20 years. When we look at high intensity conflicts against near peers like Russia or China, we're looking at a casualty rate of 30 to 50%, right? That's unheard of during our generation, during my lifetime, right? And it will quickly overwhelm any healthcare systems that we have in military medicine. And we're doing a lot of innovation on that side. And without going too far down the rabbit hole, we're talking about drones that can loiter and potentially pick up, after a casualty incident like that, potentially pick up wearable devices. Okay, so now I've got one medic for a platoon of 30 that's been hit, and he's got 15 casualties. Maybe he can help identify quickly, or this technology would be able to help identify quickly who he needs to treat. Because if you've got one medic for 15 casualties, that's a mass cal, right? You could argue 1 to 3. But something like that is absolutely part of this EMS military partnership we've seen from years. Even goes back to Vietnam, where we had all these medics coming back and we didn't know what to do with them, so we sent them to an established PA schools, right? So now we got physician assistants. But during times of lower conflict like now, we tend to learn from the civilian side. So it goes back and forth, just like the tourniquets, right? Tourniquets fell out of favor for a while. Yeah. And then when the wars in Iraq and Afghanistan began, we went back to tourniquets. So it's always been, at least in my mind, a military EMS civilian partnership that leads to innovation in healthcare, especially in the pre-hospital.
Yeah, well, and the blood programs that are circulating now throughout the United States and all the success that they're having is a direct result of the military research and data that was created. Because, I mean, where else could you get a large number of traumatic injuries at one time to be able to study something? Well, just, statistically, it wasn't happening in the United States in wide numbers, and it was hard to study. And then we had, events like Afghanistan and Iraq, where, oh my gosh, look at all these wounded people. This is information that is useful. And then a matter of, how best do we pull it into the civilian world? Because I remember my military time, it's, you don't have HIPAA rights anymore. Everything is out in the open and everything's done. And so things are a little bit different, but.
Well, we totally still have HIPAA rights within that, right? Within the military. But, I think when we talk about that innovation, the Ranger low titer O program for whole blood has been really, groundbreaking. Going back 10, 20 years, they started carrying blood, keeping it cool and stuff like that, putting it on the back of choppers for medics to give. And then whole blood transfusion is something we train on in the military as well. So, everyone gets typed and screened before they go over. Within the military, you already screen for HIV, for hepatitis, and other diseases as well. So, and you're incrementally screened for that. So if it's between someone bleeding out or someone getting blood, whole blood, we have the ability to transfuse there.
Yeah. Well, it's always been, of course, for my generation, you look back at things like Star Trek and Star Wars, and you're like all the sci-fi stuff, and you're like, oh, that's kind of cool. But then it starts to become true, and cell phones came out, and Wi-Fi came out, and computers that you could talk to or that could dictate back to you, and you're like, we didn't have those before. I remember Aliens, the movie where they had the Space Marines, and they were all geared up, and the lieutenant could see all their vital signs on there and know exactly when they were hurt or when something was going on, and that kind of tracking. To your point about one medic and 15, in their squad or platoon, how else are you going to track people in an environment where you can't really see them, and there's the fog of war and the noise and everything that's going on. So those type of advances as they come out, and people look at something and go, well, why can't we do that?
Well, luckily, I'm still waiting for my. Hey, just let me know when I'm gonna get my tricorder from Star Trek. So
exactly, yeah.
I'll be honest. I don't think we're that far off with the data, right? Answering a few questions. I can tell you, I've got my oldest kid just went off to school. He would like to become an Army doctor, and I think if he were to become a provider by the end of his career, they will have something like that at the end of a 20 to 30-year career. It'll be something that as I leave this earth. We just think is unfathomable, but it'll be commonplace for the next generation. So there's always that apprehensiveness, right, of not trusting the machine. It comes back to us. The data we put in is the data we'll get out.
Yeah.
There's of course, rightfully apprehension, Skynet versus Baymax, right? And I like the lovable Baymax, and I hope we're going that route. And we still have control over it. So I think, yeah, I really think we're in for a great next 5 to 7 years where we're going to see a lot of innovations in AI. I know Donnie Woodyard's he's got I think a book coming out on AI and EMS shortly as well. So
yeah, that actually I think it just hit in the last couple days. I think it just came out. So yeah, like I mentioned, this is a hot topic, and a lot of people are talking about it and how best to utilize it. You mentioned the protocols or the screenings of individual patients. Documentation, things like that are all ideas of could this technology help us do our jobs better or more efficiently? And the answer is always, well, yes, it could. Then the answer becomes, okay, how best to be able to utilize it? Could we make it manageable to be out on an ambulance? And if your service has 5 ambulances and you're in a rural area versus 100 ambulances in an urban area, do you have the ability to be able to deploy these type of things? Or right now, is it just too expensive to do? And, we've got to pick and choose how best to utilize the resources that we have.
Yeah, there was one Prius that was first, right? And that was probably pretty expensive.
Yeah.
But there's always that first mover advantage, right? And then there's the secondary adopters after the price starts coming down a little bit, whether it be a Prius or an iPhone, right? As the price comes down and technology becomes a little bit more commonplace, I think we'll see larger adoption across the not just the United States but across the world.
Yeah. Well, and there's also proof of concept that goes along with that as well. There's always, one group that is very, out there, very, technology affluent and willing to take those risks in it. And then there's the group that is like, well, I'm going to wait and see how this goes. And, once they get some data, then I'm going to be more comfortable doing it. It's always an ebb and flow, and there's a process to this, but I agree with you. I think this is an exciting time. I think there's technology that might have come out earlier in the progression of EMS that were like, yeah, that's not for us, or it wasn't quite the right time for us. But now things are changing a little bit, and we're looking at this very differently post-COVID, and then of course post Iraq, Afghanistan, and the military operations, being able to see the data that was coming out of those. The way that we're looking at things is a little bit different in EMS than it was, back in the 70s and 80s.
Yeah, Johnny and Roy would really be blown out,
Yeah.
Blown out Squad 51 right now if they could see what's going on in the world.
Yeah. Well, Colonel, I really want to thank you again for taking time out of your day to speak with me. Any closing messages for the group in reference to AI and technology?
No, I think we just hit on it, Doc Lee. There's going to be early adopters as it becomes a little bit more commonplace. I think we'll all get a little bit more comfortable. Some of us will leave EMS. The new generation coming in will be more comfortable with it, right? And it's just the ebb and flow. At one point, I'm sure someone was uncomfortable with, maybe just 10 years ago with basic EMTs being able to pass Narcan or epinephrine, through EpiPens, right? But that'll become more commonplace. So, no, thank you for having me. I'm glad I was able to share a little bit of, my Army knowledge and how that ties into EMS. I'm absolutely happy back here in Central Pennsylvania, getting back on the rigs with Center Lifelink, and just driving around town and back where it all started 30 years ago. It's full circle for me.
Yeah. Well, welcome home. Thank you for your service. And, we look forward to hearing from you more about AI or anything else that piques your interest in EMS.
Thank you, sir.